Thank the gentlelady. If I may, Doctor, I'm going to, we'll be talking about a lot of different things, so I'm going to pose a question, and then shortly after that, I'm going to need to leave and turn over the gavel to Mr. Harris, and then I'll come back. So, but CDC budget for FY 2016 makes critical investments in many areas, with funding prioritized for preventing opioid abuse and overdose, which you discussed in your testimony, reducing viral hepatitis-related illnesses and death, and other critical areas. There's a key opportunity to ensure that some of the most underserved areas of our country are receiving public health investment. However, many of the grant programs CDC administers are geared towards state-level public health entities. Historically, this has meant that tribally operated public health centers are often left out of the funding. I know you've made some exceptional efforts to begin to reverse that. So I'd like you, if you would, to inform the committee some of the initiatives underway to try and make sure that in Indian country, historically one of the most underserved parts of the country, we're seeing that our fellow Americans are getting adequate health care.
Thank you very much. Our first approach here has been to work on a nation-to-nation basis with tribal leaders. We have twice a year consultations, once at CDC, once at one of the tribes, to have a free and open discussion of what the issues are. And one of the things that we heard loud and clear is they want better data about what are the problems in their communities. So what we've done is to begin to unlock that data and provide it for them. We've worked closely with tribal epidemiology centers, and we hope to see those centers grow and become essentially the health departments for tribal areas. Then looking at those tribal areas, we always try to make sure that any of our funding opportunity announcements that can be directly to tribes are directly to tribes. We fund 51 tribes directly at CDC. When funding goes to states, one of the things that they told us loud and clear was they weren't happy with how things went. So we've met repeatedly with the state health departments, and we've put into their requirements that they work closely with the tribal leaders on the grants that do go through them. But wherever possible, we work directly with the tribes. We also, for the first time ever, based on the data that we saw with high rates of diabetes, high rates of other chronic health problems, we issued a 5-year, $70 million, first ever comprehensive initiative aiming to prevent heart disease, diabetes, stroke in American tribes and Alaska Native villages. This is something that is resulting in 11 specific awards and support tribal organizations to provide leadership and technical assistance. One of the challenges that we have is we've had some very successful programs, for example, to reduce motor vehicle fatalities with individual tribes, but with so many tribes, our challenge is to try to get as broad as possible. So in this approach, we're funding some tribes specifically, but also funding tribal organizations to do a cross-tribe effort to increase the health promotion and health prevention activities there to better protect tribal members from avoidable health risks. One of those has been in the motor vehicle area. We've been able to show real improvements. The numbers in motor vehicle fatalities are very concerning. American Indians and Alaska Natives are injured or killed in motor vehicle crashes far more often than any group in the U.S., as so many health disparities fall disproportionately on tribal populations. And we've shown that by working with tribes to find the strengths within those communities, we've been able to greatly increase things like seatbelt use, car seat use, reduce things like alcohol-impaired driving, and those are successes that we now want to generalize to other tribes. Similarly, going back to some of the healthier tribal nutritional habits has been very successful. We want to identify those successes, support communities, and spread them to other tribal nations.
Well, I want to take this opportunity to thank you very much. You've been a real leader and a game changer in Indian health, and the sorts of programs you're pursuing, frankly, we should have been doing a long time ago. I'm really pleased that you've taken some of your resources and directed them in this way. With that, I'm going to recognize my good friend, the ranking member of the full committee, and switch the chair, if I may. Thank you very much. If I may, Dr. Frieden, let me take you to another area that I've got some interest in, and that's the strategic national stockpile, which holds, as members of this committee know, a lot of pharmaceuticals, antidotes, other medical supplies. Can you give us some idea about, number one, when these various medications expire, if you will, and how do you go about replacing them? What's the control mechanism you have so that we have an outbreak of something, you have what you need to respond quickly?
The Strategic National Stockpile is a national resource. It currently holds about $6 billion of product in it. We have centers for it around the country, so we could deliver countermeasures to any community in the U.S. within hours. It is expensive. The process is overseen by something called the FEMC, the Public Health Emergency Management. Well, I'll have to get the exact abbreviation, Countermeasures Enterprise. And the FEMC prioritizes over a multi-year period what we want to try to purchase. If we purchased everything that the FEMC recommends, that would be many billions of dollars more. So one of the things that we've done is to have studies in conjunction with the FDA that allow shelf life extension of the products in the strategic National Stockpile. So we can do potency and other studies to determine that, in fact, although they may officially have expired, they're still good, they're still as active, and there's been no decrease. They may be freeze-dried or lyophilized so they don't degrade in any way. Second, we've done some dose-sparing studies to see whether we could use lower dose and get the same results. So we try to be as diligent stewards of the public dollars as we can be. That's the process in general that we go through. There are some drugs and vaccines that expire, and to the extent resources allow, we then use additional resources to replenish those.
When you're dealing with pharmaceutical producers, are you able to buy in bulk? I mean, just the normal sort of good practices thing that you would do, and frankly, how cooperative are they in producing what you think you need in volume?
We do find that we're able to negotiate with manufacturers, but sometimes there's only one manufacturer, and that makes the negotiations challenging. The process of getting them to produce a product is a cross-government process that includes BARDA, which will contract for the early development and kind of the first batches, if you will, of products, and then the ongoing procurement would fall to the SNS.
Just for the record, if you need some help on that, I hope you're very forthcoming with Congress, because in many cases, federal government is not only the largest purchaser, but has done a great deal of the initial scientific work on these up front. And this is one where private industry needs to give the federal government, I think, a break and certainly be responsive to your needs. It's just this is not an area to unduly profit from, in my view. But thanks for your work in that regard. Additional question, and I hope I haven't not covering ground, having missed a number of these questions, but particularly interested when you laid out early on in your tenure what you called the winnable battles, so to speak, places where you thought we could make a big difference in your tenure. One of those was obesity, and where I think we've had a great deal of bipartisan concern, some wonderful work, obviously, from the First Lady in this area. But I'd like to get an update on your progress there and how you think we're doing.
We feel that the winnable battles approach has been very helpful. It's allowed us to identify areas that are major health threats where we may or may not succeed, but if we focus on them, we're more likely to succeed. We set accountable, specific goals in 6 different areas. I can say that in at least 5 of those 6 areas, we've made some progress. In some areas, we've actually exceeded our goals. And the approach of setting ambitious goals and holding ourselves accountable for accomplishing them is one that we think is a very important one. It has pervaded CDC and the funding that we provide to state and local health departments, many of which have then adapted or adopted some of these to their own practice. In terms of nutrition, physical activity, and obesity, we've seen variable progress. One of the specific areas that we wanted to see an improvement in was an increase in the proportion of women breastfeeding, and we've seen that increase over the years. That's important. That improves the mother's health and the child's health, and there's growing evidence of how important breastfeeding is. We've also seen some increase in the number of people who are walking regularly, and that's encouraging. In some parts of the country, we've seen reductions in childhood obesity for the first time in a generation. Not nearly as much as we'd like, not nearly as widespread as we'd like, and honestly, not nearly as well understood as we'd like. But we are seeing decreases, particularly in younger children, in communities throughout the U.S. And now what we want to do is better understand what's driving those decreases and to make sure that they continue, that we extend them, and also that they extend not just for young children, but for those children as they age in.
Thank you very much, and I want to move now, obviously, our distinguished ranking member, Mr. Laurel.
Thank you very much.
I don't want to associate myself with the gentlelady's concern in terms of ethnic and racial diversity, and I must say I'm going to take your testimony and send it to OMB and tell them they really owe you, because you've been very, very kind not to throw them under the bus. But
have to say it, but we can.
yeah, and absolutely right. And you know, this is one where my friend and Ms. Roybal Allard make a really good point, and I say that as a Native American. And I know, frankly, that this is something that all of you wrestle with very professionally. It's a tough issue, but it's a very important one. I want to thank my friend for putting a spotlight on it, because it certainly needed to be done. And the time I have left, and we just to give everybody notice, we're going to try to be careful, because we've got a 10:30 hard stop. We could keep you here a long time because there's a lot of bipartisan interest in this, but out of courtesy, we have the president of Afghanistan here, and we want to give him the audience that he certainly deserves in Congress. But in your budget request, you have $68 million for prescription drug overdose, and that's something, as you know from the questions, there's a lot of concern with, certainly a lot of concern by the chairman of the entire committee. In your professional opinion, how much would you really need to turn the tide on this kind of problem? I mean, it is a huge problem with lots of ramifications, and we appreciate what you're doing. But if you were looking and you got a blank sheet of paper and you could do what you wanted to do, you know, give us some idea of the dimensions of the problem that we're talking about.
Well, one of the things that we've begun looking at is what are the costs of prescription drug overdose societally. There's an estimate from many years ago that it was in excess of $70 billion. There's some methodology issues of how do you calculate it, but it's a lot of money that it's costing society. What we've proposed is one of several programs on this topic across HHS. Treatment needs to be increased, and that's the purview of SAMHSA primarily. I think there's a real value to increasing education and information about the harms of prescription drugs. I don't think it's well understood, not by doctors, not by patients. These are dangerous medications. They're highly addictive. You only have to take a few doses to become addicted potentially for life. And they're very dangerous. If you take just a little bit too much, it suppresses the respiratory system in your brain, and you can stop breathing and die. So I think there are certainly many needs. We could get back with the full assessment, professional judgment of what it would take to address this. But I remain optimistic that we can turn this around. Not going to be easy, not going to be quick. But this was a problem that was fundamentally created by bad prescribing practices, and it can be ameliorated greatly by improving those practices and providing additional services to patients and to physicians. When I was in medical school, I had exactly one lecture on pain. In that lecture, the lecturer said, if you give an opiate medicine to a patient with pain, they will not get addicted. Completely wrong. But a generation of doctors was taught that, and it's wrong. These are dangerous addictive medications, and I think we could do more to inform both the public and professionals about that.
Well, we would appreciate any additional information you could give it, because this is one of those issues that I really think, you know, we're going to have to think about a multi-year approach and how you deal with it. But I think there is genuine interest and commitment on this committee to try and work with you on that. So again, we appreciate what you're doing now, but your best thoughts on this, as opposed to budget restricted considerations, which I know you have to work with, and I appreciate that you do, would be very, very welcome. I'm going to stop my questioning there, because I certainly want to give the ranking member an opportunity to pose whatever sort of cleanup questions she wants to pose.
Thank you, Mr. Chairman, and I think we can send a bipartisan message to OMB.
I think we just did.
Hear, hear. Just a couple of final questions. I understand that researchers are planning to enroll 6,000 to 8,000 health workers in the Ebola vaccine trial in Sierra Leone, supported by CDC and supported by Merck. Can you give us an update on the status of the vaccine trial? When is it scheduled to begin? How many health workers are expected to enroll? How long will the trial last? And the other question is, I've read reports that the health workers in Sierra Leone are concerned about the vaccine trial. What has CDC done to build trust with thousands of individuals who are being asked to participate?
Thank you very much. I'll turn to Dr. Schuchat, whose program is leading that effort. I will comment that our response to Ebola in West Africa has been the largest response in CDC's history. We have had thousands of our employees working on Ebola either in this country or around the world. We've had 40,000 person work days in West Africa of our scientists and disease control professionals. And we've seen the CDC staff really be pivotal to the organization and progress that's been made in the outbreak in Liberia, Sierra Leone, and Guinea. In Sierra Leone, we've pursued a trial of one particular type of trial of the vaccine that complements the work that's been done by NIH in Liberia with a different vaccine approach, and in Guinea by the World Health Organization and other international partners with yet a different vaccine approach. Dr. Schuchat?
STRIVE is the Sierra Leone trial to introduce a vaccine against Ebola, and it is expected to launch next week. This week we're actively training in good clinical practices and all the details of the protocol. The large number of Sierra Leone workers who will be implementing the trial. We've had tremendous partnership from the College of Medicine and Allied Health Sciences in Sierra Leone and the Ministry of Health and Sanitation there, and leadership in the chiefdoms and districts involved. We've really focused on engagement of the stakeholders, the families, the participants, the leadership of the country to address the questions, concerns, and understanding. The trial targets healthcare workers and frontline workers who are at higher risk of Ebola, and it is intended to target about 6,000 such healthcare workers and to last for about a year after it's initiated. We have an international data and safety monitoring board that's overseeing the ethics and the safety of the trial, and we're really pleased with the partnership and the trust building that's been going on with it.
Great. Let me ask a quick question, because I want to ask about viral hepatitis, where you've increased your budget. But with regard to the vaccine, this is the HPV vaccine. And only 1/3 of girls receive all 3 recommended doses of the HPV vaccine. Low rate, 50,000 girls will develop or could develop cervical cancer that could have been prevented. Is this more a matter of information about benefits of the vaccine, combating misinformation? Should we require vaccine for kids, boys and girls, to be able to enroll in school?
We think there are a number of factors that are delaying the uptake of HPV vaccine among the recommended teen vaccines. And as you say, too many teenagers aren't getting the vaccine compared to the good uptake we're seeing with the meningitis vaccine and the whooping cough booster. We think one of the key factors from our research is the way clinicians talk about the vaccine. Instead of saying, today there are 3 vaccines I recommend, they prevent cancers, whooping cough, meningitis, they're giving mixed messages. And so we're working now with the American Cancer Society, with clinician groups around the country and with state and locals to really help provide better tools for clinicians. We think most parents actually, when they get the facts, are very interested in protecting their kids from future cancers.
And I know you've had to battle with misinformation on that effort as well. So 4,000 women die every year of cervical cancer. We can look at helping to prevent that. Viral hepatitis, you double the budget. Talk about that and talk about treatment and what your plans are.
We hope to be able to strengthen state and local capacity to find new infections and to link people who are infected to treatment. This is a major health problem in the U.S. We have 3 million people with hepatitis C and more than 1 million with hepatitis B. Most of them don't know they have it. And a recent estimate by CDC scientists suggests that we could prevent more than 300,000 deaths of Americans by scaling up effective detection and treatment.
Okay, and it's an expensive treatment, I might add.
Thank you very much. Mr. Dent has valiantly been struggling between various hearings, so I want to give him the opportunity for the last questions for the committee.
Thank you, Mr. Chairman. Actually, it wasn't between hearings. I have to confess that I would ordinarily not miss a gathering with the CDC, but we have some people who provide valuable medicinal services in my district, Boston Brewing Company. Sam Adams, they do not brew it in Boston. They brew it in Allentown, Pennsylvania, and Mr. Koch, who's a TV celebrity now, and I had to make sure You bet, and we make a lot of beer where I live, and we're very proud of that. So that's why I was detained to keep the people at home happy. But a couple things. First, thank you, Dr. Frieden, and your entire team for keeping me informed on the Ebola diagnostics progress that's being made, or we hope is being made. And could you just please tell me how the development of rapid testing technology is developing or progressing? Is CDC working with other agencies like BARDA, USAID, DOD to support this innovation? And what happens when the development's complete?
So the testing for Ebola is currently done by something called a real-time polymerase chain reaction. It's a highly accurate way of testing for Ebola. You can do it from an oral swab or from blood. It takes a highly specialized laboratory. Once you get the specimen into that laboratory, it just takes a few hours, but those laboratories can't be everywhere. We have used something called a lateral flow assay for other pathogens. It looks like a dipstick that's sometimes used for a pregnancy test and gives an answer in 20 to 30 minutes. We invited any company that wanted to come sit with us and work in our laboratories, that we would help them develop a product and help them get it out there, because it's in everyone's interest for that to happen. Several companies took us up on that, and at least one of them now has proceeded to, we've worked with them to optimize that test so that it tests against multiple parts of the Ebola virus. We don't think it will be quite as sensitive as that real-time PCR, so there'll be some false negatives, if you will, but we are hopeful that it will be just as specific, so there would not be a large number of false positives. That could be extremely helpful, because you could then go out to someone who had died in the community or in a hospital, and in less than a half an hour have a preliminary answer. If they were positive, if that test was positive, you'd know it was Ebola, and you could accelerate your control measures. If it were negative, you couldn't assume it was negative, and you'd have to do further testing. But actually, I believe this week we have our lead laboratory scientist for the Ebola response in both Guinea and Sierra Leone, working on a field test of a prototype of this product, and I'm personally very excited that this could be an important tool in our response.
And which company's product is that?
That's OraSure.
That's OraSure. Constituent company, I'm pleased to tell you.
I had a suspicion.
We're the center of innovation in many areas. But one other quick question. What about the establishment of a stockpile of emergency supplies to identify and treat Ebola cases? Is there a global effort to support this activity when a new threat presents itself? And will we be stockpiling medicines, diagnostics, special protective gear here and abroad to meet these challenges when they present? Or if so, how and where will these emergency preparedness measures be housed?
Thank you. I'll answer that, and if I can, I just neglected to mention one thing in your prior question, which is there is another test which is FDA approved, called run by a company called BioFire, which we're also implementing in West Africa. That's also a PCR, so it requires a little bit more technology, but it's about a 2-hour turnaround time for a test. In terms of the Strategic National Stockpile, we've already scaled up to provide protective gear so that that would be available for the number of patients who'd be needed. Hospitals have stocked it, but we've also stocked it in the Strategic National Stockpile. We've looked at, currently there are no proven treatments, no proven vaccines. If there were, then we would look at potentially procuring those for the stockpile. But the stockpile is important in that response within the U.S. Globally, we need to strengthen our ability to surge into countries when there's a problem with a stronger World Health Organization and stronger other entities globally to do what CDC has done and put hundreds of staff on the ground in a question of just a few days or weeks.
Yeah, and finally, just to follow up on Representative Delores' comments on hepatitis C. I came in during her questioning, so I hope I'm not redundant. The hepatitis C screening results are, you can get those within 20 minutes now. Same company, by the way, OraSure does HVC diagnostics. This, coupled with the dramatically improved treatment options, can improve the lives of many Americans. As you know, How is CDC taking advantage of these developments now with this?
Our budget proposal is to double our funding for viral hepatitis so that we can support state and local entities to scale up testing and linkage to care. We know that many people with hepatitis C and hepatitis B don't know they're infected, and many who are infected have not been treated, including those who have advanced infection and clearly would benefit from treatment.
Thank you. And my time's up, and I'm going to yield back.
Thank you very much, and our time up, sadly, is up as well. But Dr. Frieden, Dr. Bell, Dr. Sugar, I want to thank you very much for taking the time. Your testimony is extremely helpful to this committee, but just more importantly, just thank you and the wonderful people that you work with and represent for what they do for the American people and, frankly, for people all around the world every single day. Your work is greatly appreciated and much admired on this committee on both sides of the aisle. So, again, thank you for coming to testify, and we look forward to working with you through the budgetary process.
Thank you very much.
Thank you. We're adjourned.